Rotator cuff tears. They're incredibly common, aren't they? Especially, well, as we get older.
They certainly are. A very frequent issue we see.
But what happens when it's not just a simple tear? When it's, massive? Maybe even irreparable?
Yes, causing significant pain, limiting arm function quite severely.
We're talking about tears involving multiple tendons or just very large ones, maybe bigger than 5 centimeters.
Exactly. And that can lead to some quite concerning secondary problems like muscle wasting atrophy and fat building up within the shoulder muscles.
And this isn't a rare problem, is it? It affects a fair number of people, particularly over 60.
That's right, a significant percentage. And while we always start conservatively,
Physio, injections, that sort of thing.
precisely, non-surgical options first. But for these larger, more complex tears, surgery often becomes, well, necessary.
And the aim of the surgery, then?
Fundamentally, it's about trying to restore some functional mechanics to the shoulder joint, give it back some stability.
Right. And for these really tricky cases, the massive irreparable ones where a standard repair just isn't on the cards, surgeons have different approaches.
Yes, different techniques have been developed.
So today we're taking a deep dive into a recent meta-analysis. It was looking specifically at comparing two of these surgical options, wasn't it?
Correct. Comparing partial repair, or PR, and superior capsular reconstruction, known as SCR.
Okay, let's break those down a bit. Partial repair, PR.
Partial repair is essentially about, well, working with what's left of the rotator cuff. You aim to balance the remaining forces around the joint.
To try and create a stable pivot point.
Exactly.
Well,
So the patient can hopefully regain some useful movement and function. It's a pragmatic approach, really.
Okay. And the other one, superior capsular reconstruction, SCR.
SCR is more reconstructive. It usually involves using a graft material.
A graft? Like what?
It could be donor skin tissue, an allograft, or sometimes fascia from the patient's own thigh, autograft. This creates a new layer on top of the joint.
And the point of that is?
The idea is to restore that crucial superior stability. That's what's lost when the upper part of the cuff is completely torn and retracted. This SCR technique was first described back in 2012.
And both TR and SCR are seen as acceptable options.
Yes, they're both in the surgical toolkit for these difficult situations.
But the big question is, how do they actually stack up against each other in practice?
Oh.
Is one better?
That's the key question, isn't it? And that's what this paper set out to address directly.
Their goal was to compare the results, pooling data from existing studies.
Correct. Something that hadn't been done in quite this specific comparative way before.
And you're here to help us unpack what they found and, crucially, what it really means.
Absolutely. It's quite fascinating because although both techniques have been used for a while, especially SCR, since 2012.
Over a decade now.
Indeed. Getting clear, high-quality comparative evidence has actually proven quite difficult. This meta-analysis tried to synthesize whatever was out there.
Okay, so methodology. How did they go about it? Searching databases, I assume?
Yes. They searched the major medical databases covering a decade, 2013 up to 2023.
Looking for studies comparing SCR and PR in these specific patients. Massive tears, failed non-off treatment.
Exactly. They were open to various study designs initially, RCTs, cohort studies, etc.
But what did they actually end up with after filtering everything?
Well, they started with over 1,000 potential articles, but after applying their strict inclusion criteria, sifting through, they ended up with a very small number of studies suitable for a direct comparison.
How small are we talking?
Critically small, really, for this kind of question. Just 4 studies met all the criteria for the final meta-analysis comparing SCR and PR.
Only 4. Out of more than 1,000 possibilities, it does sound low.
It is low, particularly given how common the condition is and that these procedures are being done.
And what type of studies were they?
This is really important. All 4 were cohort studies.
No randomized controlled trials.
None that met their criteria for pooling data comparing SCR and PR directly. So the entire analysis rests on observational cohort data.
Which is generally considered a lower level of evidence for comparing treatments, isn't it?
It is, yes, compared to RCTs. These 4 cohort studies, together, included a total of 235 patients.
Okay, so 235 patients across 4 cohort studies. What did pooling that data actually show? What were the outcomes they looked at?
They focused on a range of important outcomes. The primary one was the constant shoulder score.
That's a standard measure for shoulder function and pain.
Yes, widely used and validated. Then they looked at secondary outcomes, too, things like the DSH score.
Disabilities of the arm, shoulder, and hand score, patient reported.
That's the one. Also the acromiohumeral distance, the space on X-ray between the arm bone and shoulder blade.
Which can decrease in these big tiers.
Exactly, it can collapse. They also compared reoperation rates, forward flexion, how high you can lift your arm forward in pain, using the visual analog score, the VAS.
Right, the crucial bit then, pooling those 4 studies, comparing SCR and PR across all those measures. What was the headline finding?
And here's perhaps the most significant result, or maybe non-result, depending on how you look at it.
Okay.
The paper reported no statistically significant differences between the SCR group and the PR group for any of the primary or key secondary outcomes analyzed.
None at all. Not for the constant score, DAHH, AHD, reoperation, flexion, pain.
No statistically significant differences found across the board based on the pooled data from these specific 4 studies. Neither technique showed a clear statistical advantage over the other.
Wow. Okay, that sounds quite definitive. No difference. But you flagged the low evidence level, the small number of studies. Does finding no statistically significant difference actually mean PR and SCR are proven to be equally good or equally bad?
That's the crucial distinction. And it's vital not to jump to that conclusion. Finding no statistically significant difference here does not mean equivalence is proven. What it really means is that with the limited and variable evidence from these 4 cohort studies, there just wasn't enough statistical power or consistency to detect a significant difference, even if one truly exists.
So it's less like saying they're identical and more like saying the data is too fuzzy or too sparse to tell them apart reliably.
That's a very good way of putting it. You don't have enough evidence to declare a clear winner. The paper itself is very clear about this limitation.
So inconclusive, really, not proof of sameness.
Precisely. Inconclusive regarding superiority. And a major reason for that, as the authors point out, is the significant heterogeneity observed across the studies.
Heterogeneity, meaning variability, differences between the studies.
Exactly. Even though they pooled the data, the studies themselves were quite different in several ways, making a clean comparison difficult and limiting confidence in the pooled results.
What sort of differences are we talking about? Where did this variability come from?
Several places. Firstly, the patient populations weren't identical across the studies.
How so?
Well, some might have included patients with generally more severe characteristics to begin with. Others might have excluded patients with, say, diabetes or smoking history, but perhaps included those with pseudoparalysis and really severe inability to lift the arm. These baseline differences can definitely influence outcomes, regardless of the surgery performed.
That makes sense. Starting points matter.
They absolutely do. And another critical source of variability was in the surgical techniques themselves, especially for SCR.
You mentioned the original technique used a thick graft.
Yes, the description by Dr. Mahata, often considered the gold standard, used a fairly thick 7.5 millimeter autograft, usually fascia lata from the thigh. But the studies in this meta-analysis, they often use different materials and significantly thinner grafts.
Thinner? Like what?
Some used, for example, 3 millimeter thick dermal allograft donor skin. Another used a 3 millimeter porcine xenograft tissue from pigs.
And a thinner graft might just not work the same way.
Well, biomechanically, it might not provide the same level of stability or have the same properties as the thicker autograft. That could certainly lead to different results. And similarly, the partial repair techniques weren't identical either. Different ways of stitching, like margin convergence versus side-to-side repairs, could subtly change the mechanics.
So the meta-analysis wasn't truly comparing one single SCR method to one single PR method. It was pooling data from studies using slightly different variations of both.
That's exactly right, and that variation just adds noise to the analysis.
Okay, what else contributed to heterogeneity?
Inconsistencies in how outcomes were measured and reported.
Like using different scoring systems.
Yes, or even slightly different versions. One study might use the standard constant score, another an age-adjusted version, another a quick DAH. Someone else might use a totally different patient-reported measure like the Western Ontario Rotator Cuff Index. Pulling data across different measurement tools introduces potential bias and reduces reliability.
Right, comparing apples and oranges, almost.
A bit like that, yes. And then there were the methodological limitations of the studies themselves.
Which were?
Well, as we said, all 4 were retrospective cohort studies, looking back at existing data.
Which means the surgeon chose the procedure for each patient, not random assignment.
Correct. That carries an inherent risk of selection bias. Why did one patient get SCR and another PR? While they try to account for factors statistically, It's hard to eliminate that bias completely.
And they were small studies, too.
Relatively small, yes, which limits statistical power. Plus, things like follow-up times weren't always uniform, and consistent post-op imaging wasn't always available for everyone, making it harder to assess graft healing or read tears accurately.
You mentioned the surgeon's choice. If the pooled outcomes look similar, what was driving the decision between SCR and PR in these particular studies?
That's a key point the meta-analysis looked into. Based on these 4 studies, the main driver seemed to be the specific characteristics and severity of the tear itself. Things like how far the tendon had pulled back, the retraction, and the degree of fatty infiltration in the muscle, how much muscle had turned to fat because of the chronic tear.
So it wasn't just surgeon preference, it was based on the tear's condition.
According to what's reported here, yes, SCR tended to be chosen for the more advanced, genuinely irreparable situations.
Where there was very little tendon left, or it was too retracted or fatty to repair.
Exactly, where a partial repair wasn't really feasible. PR was selected when there were still components that could be repaired meaningfully, perhaps in large tears, but with less severe retraction or fatty change.
And things like age or gender didn't seem to be the deciding factor.
The paper notes that those factors didn't appear to be significant drivers for choosing PR versus SCR in these specific study populations.
That's really interesting. It suggests that even though the average outcomes in the pooled data didn't differ statistically, the 2 techniques might have been applied to groups with different baseline severities.
That certainly appears to be the case from the studies analyzed here. One study specifically mentioned that complete tears of another cuff muscle, the subscapularis and pseudoparalysis, were more common in their SCR group.
Suggesting more complex problems to start with.
Potentially, yes. Another showed more advanced tendon retraction in the SCR patients.
So it does sound a bit like SCR was often being used for the hardest cases within this already difficult category of massive irreparable tears.
That's a reasonable interpretation based on the patient selection described in these papers. It reinforces that they weren't necessarily comparing like-for-like patient groups, getting the different procedures.
Did any of the individual studies report on things that couldn't be pooled, like, say, strength recovery?
They did mention that. Some individual studies did measure other outcomes, specific strength tests, other ranges of motion like rotation, or different scoring systems, and the authors note that one included study did suggest SCR might offer better post-op strength compared to PR.
But because the data wasn't consistent across all 4 studies,
it couldn't be reliably pooled and analyzed statistically in this meta-analysis, which just highlights another gap in the current evidence.
Okay, let's try and pull this all together then. This meta-analysis aimed to compare partial repair and superior capsular reconstruction for these big, irreparable rotator cuff tears.
Correct. Using studies from the last decade or so.
And based on pooling data from just 4 cohort studies, no RCTs found, comparing them directly covering 235 patients.
The finding was no statistically significant difference between SCR and PR for the main outcome, constant score, or key secondary ones like DHH, AHD, reoperation flexion, or pain.
And this is the really crucial point, that lack of statistical difference does not prove they are equivalent.
Absolutely not. The evidence level is low. It's only cohort studies, and there was significant variability, heterogeneity across those studies.
And that variability came from differences in the patients themselves, especially tear severity driving surgical choice.
Variations in the actual surgical techniques used, particularly SCR, graft type, and thickness.
Differences in how outcomes were measured, and the general limitations of retrospective studies.
Precisely. The analysis suggests SCR was often used for the tougher tears based on retraction and fatty infiltration, not primarily based on age or gender in these studies.
So the real takeaway isn't PR and SCR are the same. It's more like, based on the limited variable evidence we currently have, we can't confidently say one is better, and we really need better data.
That sums it up perfectly. This study really underscores the current uncertainty in the evidence. It strongly supports the author's call for future high-quality research.
Specifically, larger randomized controlled trials.
Yes, well-designed RCTs are needed to provide more robust evidence.
And maybe those future trials could look at subgroups, like comparing different SCR graft types or outcomes based on initial fatty infiltration levels.
Exactly. That kind of detailed, high-quality comparative data is what's needed to clarify the pros and cons of these approaches for different patient profiles.
Because that could really help surgeons tailor the treatment better and improve outcomes.
Absolutely. Without that stronger evidence, clinical decisions for these complex cases remain Well, less evidence-based than we'd ideally like.
It really makes you think, doesn't it? Even for common conditions and established procedures, figuring out the best approach absolutely depends on having good comparative evidence.
It does.
And sometimes the main finding of a study is simply highlighting where the evidence is weak and pointing the way for better research. If you found this deep dive useful, perhaps consider rating or sharing it. It helps others find this sort of discussion.
A very important point. Recognizing the limits of current knowledge is always the first step towards asking the right questions to genuinely improve patient care in the future.